Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, what is this right here? A lot of stones in some sort of sack. Ah, yes, gallstones. This is what it looks like grossly. We're going to be discussing this and much more in this presentation on gallbladder and biliary tract pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material, everything that you need to succeed on Step 1. Now, gallbladder and biliary tract pathology. What does this include? Well, there are some key things that you will definitely be asked about, which include biliary atresia, gallstones for sure, biliary colic, acute cholecystitis, chronic cholecystitis, ascending cholangitis, gallstone ileus, and gallbladder carcinoma. Let's start with biliary atresia. Biliary atresia is due to failure of the bile duct to develop or early destruction of extrahepatic biliary tree. Biliary atresia results in biliary obstruction within the initial 3 months of life. Biliary atresia presents with jaundice, and it may progress to cirrhosis. Histologic analysis from livers with biliary atresia shows patients to the right here, their representative microscopic findings. Note the progression of fibrosis. So gallstones, now this is important. Gallstones are called cholelithiasis. The gallbladder contains solid, rounded stones because of precipitation of cholesterol, right? These cholesterol stones. Or bilirubin, which would be bilirubin stones. And that's present within the bile. To the right here, we have a plain X-ray actually showcasing some gallstones. Now, gallstones may be due to a number of things, which include supersaturation of the cholesterol or bilirubin. Could be due to reduced phospholipids, such as lecithin or bile acids, right, which usually enhance the solubility. And they can also be due to stasis, right, the fluid just being stagnant, allowing the development of the stones. Typically, cholesterol stones, which are the yellow ones, are the most prevalent type, approximately 90%, particularly in the West. Gallstones are typically radiolucent, and that's the 10% of gallstones that are radio-opaque because of associated calcium. The risk factors for the development of gallstones include higher weight, right? Female, fertile, over 40 years old, high levels of estrogen, clofibrate use, Native American ancestry, Crohn's disease, as well as cirrhosis. These are all risk factors for gallstones. To the right here, we can see a large gallstone on a CT scan. Bilirubin makes up the pigmented bilirubin stones. Bilirubin stones are normally radiopaque. Risk factors specific to bilirubin stones include extravascular hemolysis or biliary tract infection, right? Extravascular hemolysis due to the increased bilirubin in the bile, and biliary tract infection, such as from organisms like helminths or bacteria like E. coli or Ascaris lumbricoides and Clonorchis sinensis. Now, regarding the helminths infections, what particular white blood cell would you expect to be increased in circulation? Eosinophils, right? In response to the helminth infection, right? And what else causes eosinophils to rise? Right, a number of things. It could be medications, allergies, infections, right? Okay. A common roundworm called Ascaris lumbricoides infects people worldwide, especially in places with poor sanitation through the fecal oral transmission. Delicious. The biliary tract is infected by the endemic Clonorchis sinensis, also known as the Chinese liver fluke, which raises the risk of gallstones, cholangitis, and even cholangiocarcinoma. This is a big deal. Typically, gallstones are generally asymptomatic. But complications of bilirubin stones include biliary colic, acute cholecystitis, chronic cholecystitis, ascending cholangitis, gallstone ileus, and the dreaded gallbladder cancer. Now look at this. This is a large gallstone that was obtained from a patient. Can you believe that was in their gallbladder? And here's some X-ray microtomography of a gallstone. Here's an abdominal ultrasonography showing gallstones for the future radiologists out there. Note the wall thickening and fluid around the gallbladder. And here are a number of gallstones after a gallbladder was removed, the cholecystectomy, and the stones were taken out of it, washed off, and placed for this photograph. And here we have a number of gallstones of varying sizes and dimensions. Now here we can clearly see a gallstone, and note that it is impacted in the neck of the gallbladder, leading to cholecystitis. Now let's talk a little bit about biliary colic. Biliary colic presents with right upper quadrant pain, right? So keep that on your differential when you're doing the abdominal examination. Biliary colic presents with right upper quadrant pain that comes and goes, brought on by the gallbladder contracting against a stone that is stuck in the cystic duct. If the stone passes, the symptoms of biliary colic may subside, most likely. Acute pancreatitis or obstructive jaundice may be caused by common bile duct blockage. Here we have acute cholecystitis, which is the inflammation of the gallbladder wall, We can see that on the right with this ultrasound. Note that the closed arrow points to the gallbladder with the wall thickening, while the open arrow is pointing to the gallstones. Acute cholecystitis may be due to an impacted stone in the cystic duct that causes inflammation, bacterial overgrowth, and dilation with pressure ischemia. Symptoms of acute cholecystitis include right upper quadrant pain that may even radiate to the right scapula, fever, leukopenia, right, low white blood cell count, nausea, and vomiting. Lab findings in acute cholecystitis typically show a high level of serum alkaline phosphatase, and that's due to the duct injury. If acute cholecystitis is not treated, there is a chance for gallbladder rupture. Now here, in this image, we can see acute cholecystitis with gallbladder wall thickening and a large gallstone and enlarged gallbladder as a result. Here we have a gross examination of a gallbladder that was bivalved and opened up. So you're actually looking at the internal surface of the gallbladder. Note the yellow streaks of cholesterol deposition. And here we have an H&E stain from a patient with eosinophilic cholecystitis. You see all the eosinophils? Now this image is showing histopathology of acute gangrenous cholecystitis, showing the necrosis. And can you see the neutrophils and partially sloughed off mucosa? Now here is a gallbladder that's been opened up and examined grossly, and this is carcinoma. Note the protuberant mass, unorganized growth, the prominent nodule. Now let's talk a bit about chronic cholecystitis, okay? Chronic cholecystitis is chronic inflammation of the gallbladder. To the right here, we can see an abdominal ultrasound showing gallstones and wall thickening and fluid around the gallbladder. Chronic cholecystitis may be the result of long-term cholelithiasis-related chemical injury, with or without concurrent episodes of acute cholecystitis. Chronic cholecystitis is characterized by the gallbladder mucosa herniating into the skeletal wall, i.e. Rokitansky-Ashkoff sinus, which for all intents and purposes are diverticula of the gallbladder wall, which may be microscopic or macroscopic. Symptoms of chronic cholecystitis include right upper quadrant aches and pains, especially after eating, and fatigue. Now this is important. You'll be asked about this. A porcelain gallbladder is a complication of late-stage chronic cholecystitis. Porcelain gallbladder is a shrunken, hard gallbladder because of chronic inflammation, fibrosis, and dystrophic calcification. Porcelain gallbladder findings vastly increases the risk for carcinoma of the gallbladder. Remember that. Cholecystectomy is the recommended course of action for chronic cholecystitis, especially if a porcelain gallbladder is present. And here we have a representative section microscopically from INOS expression in the gallbladder with cholecystitis with H. pylori infection and one without. Basically, this is showing that the one with H. pylori infection expressed more INOS. And here's another important topic that you must know. Ascending cholangitis. Ascending cholangitis is a bacterial infection of the bile ducts. To the right here, we can see a cholangiogram that's through a nasobiliary drain showing the common bile duct in black, with an interruption in the contour due to a large gallstone. Ascending cholangitis is typically brought on by an escalating gram-negative intestinal infection. Symptoms of ascending cholangitis include stomach discomfort, jaundice, and sepsis. There is a higher prevalence of choledocholithiasis in ascending cholangitis. What is choledocholithiasis? That's just this stone in the biliary ducts, right? And here we can actually see that. All you future gastroenterologists, you'll be seeing a lot of this. Here we have a duodenoscopy image of the ampulla of otter with pus extruding from it, indicative of cholangitis. Now here's another very important topic. Gallstone ileus, right? Must know this. Gallstone ileus occurs when the small bowel is obstructed by a gallstone. A predisposition to gallstone ileus may occur because of fistula formation between the small bowel and gallbladder as a result of cholecystitis. And here we have an image showcasing gallstone ileus. And more gallstone ileus. Now you must know this, at least be able to recognize the H&E. This is gallbladder adenocarcinoma histopathology. Note the high NC ratio, the pleomorphic nuclei. Pleomorphic means they look different from one another. They're not consistent. They're not the same. This is gallbladder carcinoma, and it is a malignant lesion of the gallbladder. The glandular epithelium that lines the gallbladder wall is where gallbladder carcinoma develops. Risk factors for gallbladder carcinoma include gallstones, acute cholecystitis, chronic cholecystitis, and the must-know porcelain gallbladder. An older woman with cholecystitis is the classic type of individual susceptible to gallbladder carcinoma. Unfortunately, gallbladder carcinoma has a poor prognosis. But you have a great prognosis because you're doing so well getting through these presentations. You're on the right track. You're going to succeed to the highest degree, right? You're getting ready. You're doing what you need to do. And I'm proud of you for that. I applaud you. I applaud your efforts. Everybody's rooting for you. Keep up the good work. If you have any questions, comments, or concerns, let me know. And I'll see you later.